Good evening, everyone, and I hope everyone's had a good day. And massive thank you for joining our webinar tonight. There are quite a few of us on tonight, and no doubt there'll be a few more joining as well. So you should all be on mute anyway. But obviously, if you're not, if I can ask that you do go on mute so we don't get too interrupted by any other background noises. My name is Christian Stewart. I'm one of the clinical education managers here at Dentsply Sirona. I'm delighted to be joined by my colleague Emma Cady, and I'll shortly be handing over to tonight's speaker, Professor James Field. But yeah, thanks again for joining that. This is the third of a four-part series of webinars that James has been doing for us. Some of you may have joined previous sessions, but don't worry if you haven't. You know, it's not like Coronation Street. You can easily pick these up individually, and these all will be available on demand on the Dentsply Sirona YouTube channel, which you'll all be sent details of following the sessions. Many of you already have, but if you haven't, we are going to be doing the final part 4 of this webinar series in 2 weeks' time on the 17th of June, same time at 7 o'clock. During the course of tonight, I will put a few links in the chat, obviously for the next webinar in this series, but I'll put in a few other links as well for some of the upcoming events we have coming up in Dentsply Sirona 2, which is the big one on my background there, which is our main education event of the year. So the webinar series is entitled Back to Basics, and having had a good preview of all of these sessions with James, I think it's really important that we all get so caught up with what we're doing that sometimes we do need to take a bit of a step back and look at some of the bread and butter stuff that we do. Are we using these products correctly? Or do we need to remind ourselves of what's in them and the optimum way in which to use some of these products? So it's been really, really good. Emma and I have really enjoyed sort of revisiting these topics, and I'm sure you'll get a lot out of it tonight, guys, as well. We'll have plenty of time for questions at the end of the session, but if any of you do want to stop and ask a question, please do. Take yourselves off mute and ask, or pop it in the chat. Emma and I will be keeping our eyes on that. So, and then when we get a chance, we'll stop and ask James the question. But as I say, we will have plenty of time for Q&A at the end as well. Following the webinar tonight, you'll be sent an email asking you for your feedback. You know the drill with this. Please do give your honest thoughts on this. It's great to hear back. We want to do more of these sessions. We do think they're extremely useful, but it'd be great to get your feedback and your opinions on how things have gone and any of the topics you might want us to cover at future sessions. Once you've completed that feedback, you'll then also be sent your CPD certificate for joining tonight as well. Okay. So as mentioned, in addition to the next series in the webinar that I'll put the links on for, we do have some other events, which again, I'll share these links with you in the chat, so you're aware of other upcoming events we've got within Dentsply Sirona. So absolutely delighted to be joined by, once again, by Professor James Field. Some of you will know James. James is Director for Learning and Teaching at Cardiff Dental School, as well as a Professor of Restorative Dentistry and an Honorary Consultant in Prosthodontics. James has been a key opinion leader for Dentsply Sirona for a number of years. I've had the pleasure of working with James many times. He has extensive experience in delivering innovative teaching in restorative dentistry, for which he has received international acclaim. So rather than me carrying on talking now, I'm going to hand over to James. Please do enjoy the presentation tonight. So if you do have any questions, please do pop them in the chat. I'll hand over to you, James, and I'll come back to you towards the end of the night. Thanks very much.
That's great. Thank you very much indeed, Christian, for that introduction. Good evening, everybody. It's a real pleasure to be here talking to you all. I'm just going to share my screen, make sure that this is all working properly before we go any further. So just bear with me a second. Christian, you can let me know if you can see this okay.
Yeah, coming through perfectly, James.
Brilliant. Okay. So let's get started. As Christian said, I'm based in Cardiff Dental School, the only dental school in Wales, and I've been asked to put together this series, and as he said, this is number 3 or 4. If you haven't seen 1 and 2, that's not a problem at all. You can go and find those on through the Dentsply Academy, and they're on the YouTube channel, I think, as well, Christian. So we can also put some links into those. But I do pick up on a few things again tonight that we're going to be talking about. Let me move on and tell you the kind of things that we're going to be looking at tonight. So we're very much back to basics. I know Christian was saying that often we forget the fundamentals of why we're doing things, but that philosophy of going back to basics is very much underpinning what I do, what we do in higher education, and trying to make sure that people remember the fundamentals of what they're doing by understanding the basics. And I remember when I qualified and went into practice, a lot of the time I ended up doing things because I'd picked up ways of doing it, or I thought that perhaps ways were more efficient or more effective, but then I actually forgot a lot of the reasons and the fundamental reasons behind why I was doing things in a particular way. So hopefully you'll find tonight useful, just to go back and remind ourselves of why we do things in particular ways. And the things we're going to look at tonight are those fundamental concepts of posterior cavity design. There's a lot of opinion out there, ranging from published opinion from subject matter experts in terms of how we should operatively intervene with teeth, through to very popular opinion on social media by people who run very successful practices. And neither one is more right than the other necessarily, but we need to go back to basics and understand what we want to achieve. We're also going to look at the options and indications for different restorative materials. And the particular driver for this series is the fact that we won't be using amalgam anymore. So there's a real focus here on composites and exploring the challenges of, and perhaps some of the solutions for managing subgingival margins. And we talked a little bit about that in the previous webinars. So the statement of the problem then is that we have waved goodbye to dental amalgam. Some of you might be jumping up and down saying yes. But if you're anything like me, you'll probably be shedding a little tear about the fact that amalgam is no longer part of our armamentarium on a routine basis for treating patients. So this is old news now, but the EU has phased out dental amalgam under this particular regulation for use. And we now can't use, manufacture, import, or importantly, export dental amalgam from the EU, which poses an immediate problem for the UK, for example, who might want, even if they wanted to keep using, or we wanted to keep using amalgam, we can't really source it. So this is already happening, and you may have used up your stocks of amalgam already, but you will certainly find it extremely difficult to find any more. So at this point, I just want to pause and take a slight change in direction to think about some policy. And the policy that I've mentioned in the other webinars, but I'd like to mention again, are around the International Organization for Standardization, the ISO standards. You may have heard about these in daily life, actually. They govern so very many standards that we are governed by, from how things are manufactured through to safety standards, environmental sustainability standards, etc. And they're globally recognized, and they provide a robust framework for people to manage systems and operations. And believe it or not, we have ISO standards for our materials that we use: dental amalgam, dental composite, and glass polyalkanoates, essentially glass ionomers, and many more as well. So the first point that's back to basics is to understand a little bit about these standards, because the standards define what our materials should be, what they should do, and how they should behave. Many of you using composites won't necessarily know about the ISO standards, and you might not, even if you did, know about what they mandate that composites can do. So let's have a little look at those. The composite ISO standard is 4049. That's a bit of a pub quiz question, but it is useful from time to time to know that there's a standard, a particular standard governing composites that you are procuring and that you're using, And it says that the composites have to comprise fillers and a base resin, which is usually methacrylate or acrylate. And you might remember that from when you were learning about the composition of composites as an undergraduate. And those fillers may be quartz, silica, barium, or if we look towards the more recent spectrum, no pun intended, of composites, then the filler may actually be the cured composite itself. And we'll look a bit later on at why that might be quite an innovative thing to do or a useful thing to do. We have triethylene glycol and derivatives of it, which control the viscosity. And if you find yourselves in Dentsply's labs or other companies' labs, then it will look very much like a chemistry lab with different glass beakers with different concoctions in them, some of them very runny, some of them very thick like treacle, and everything in between. And what the chemists are doing is they're choosing different ethylene glycol, other derivatives of different viscosities to give the final composite different handling characteristics. And of course, there are activators and initiators in the composite, so it can go through and begin its curing cycle. Now, what the standards say is that any composite that you buy, according to the standard, has to have a minimum depth of cure of 1.5 millimeters. And there has to be a minimum of 50% conversion of the monomers to polymer. And this perhaps gives an indication of how dated the standards are, because 50% conversion, I don't think, is a particularly high number. I think we could aspire to have a higher conversion, and practically we do with our modern composites. But it also sets standards around how strong composites have to be. So they have to have a certain flexural strength after they've been cured, which is 80 megapascals. And also they have to limit the amount of water that they take up into themselves. Now you might think, but once I've cured composite, that's it. It's completely sealed. Well, that's not actually true. The matrix around composites, the resin matrix, at the nano level does allow fluids and water to move in and out, particularly at the surface. And what that does is over time, it causes degradation of the resin matrix and loss of the fillers. So you can imagine if that was at the margin of a restoration, and that's going to really affect the marginal integrity. So there's a limit as to how much water sorption the composite can display. And at the same time, there's also a limit on how much it can actually leach out from the material as well. So that's called the water solubility. The problem with leaching outwards is that we get pretty nasty things in there, like formaldehydes, methacrylic acids, and some of the work that the team at Sheffield University have done shows that actually you can measure some of those things in people's urine only a matter of minutes after having composites placed. Probably one of the good reasons for routinely using dental dam and high volume aspiration. But you know, these materials are chemicals, and they might be touted sometimes as biocompatible, but we have to be careful about how much solubility they display. And that's where these standards come in as well. Interestingly, one of the things we talk about a lot with composites is their ability to reduce stress due to polymerization shrinkage. Actually, that's not part of the standards, and maybe that's another calling for how the standards should be updated. Typically, though, in modern composites, you can expect that to be anywhere between 1-2%, sometimes less than 1, sometimes a bit more than 2. So what goes on in terms of research in this way? Well, I'm going to put the paper up here from Ollie Bailey and his team in Newcastle a few years ago. Really interesting paper looking at amalgam phase down. This was a UK-based study of over 1,500 general dental practitioners, so a reasonable number. And what it's showing is that when it was carried out, the most commonly used restorative material in molar teeth was amalgam, and that might not be a surprise to you at all. What's interesting, though, is that dentists and therapists took 45% more time to place composites that were MODs than amalgams. And that's where this becomes more of a concern, because we don't want composite to be taking significantly longer. than other materials which were being used. And also it showed that people had concerns over the suitability of composites, particularly in larger cavities, particularly that MOD cavity. And also there was a higher complication rate reported for large posterior composites. So in summary, what it was showing was that amalgam and the use of amalgam was deeply embedded, particularly in UK dentistry, but at the same time, there was a need to really drive towards some solutions to overcome some of these challenges, some of them actual challenges and some of them perceived challenges as well. I'm also going to just mention sustainability. I think this is really important. It's on a lot of people's agendas. But we've got a good opportunity here in dentistry and oral health to improve the impact that we have on the environment. There's a paper here from Brett Duane at Trinity College Dublin and various colleagues around the use of materials, resources in dentistry, the carbon emissions from those. What not a lot of people realize is that the biggest carbon footprint in oral healthcare comes from patient and staff travel. Most people think it's perhaps the plastic waste, the non-recyclable waste, the chemicals, but really it isn't. It's travel. And we also know that when we are rehabilitating patients with composite, that they have possibly one of the highest potentials for failure than other materials because of the technique sensitivity around bonding, around curing. And most of the time when composites fail, it's usually because of inappropriate bonding protocols. So one of the things that we can do to make sure that we are minimizing the impact on the environment is to do it right first time. And we spent some time in the previous webinars talking about how we can maximize at least the use of kind of bonding technology to improve the likelihood of longevity in those restorations. So this third webinar is a kind of a culmination of some of the matters we've been talking about in webinar 1 and 2 around improving our outcomes. And so these were listed just here. They were to make sure that we are being minimally invasive. They were to ensure that we can provide quality tooth preparations which meet recognized criteria. And that's one of the things that we'll be talking about tonight again. And we need to make sure that we've got adequate adaptation of our matrices, regardless of which matrix system we use. It should be adapted well and it should be doing its job. And we'll talk a little bit more about what that means later on. And we also need to make sure that we are optimally bonding to substrates. And we talked last time about that not just being seen as sticking the composite into place, but a process which makes sure that you've got full coverage of the bonding area. You've got an optimized bond. You don't have any marginal degradation. You don't have any micro leakage. You don't have any micro cracks, which are kind of perpetuating those problems. And we also need to make sure that we can contour and finish our restorations appropriately, or that we minimize the time that we spend doing that. And finally, we need to make sure that we make appropriate decisions about, and I use this term really carefully, predictably restoring teeth, and making sure that we've got patient consent for that. We'll talk a little bit about that later on as well. So if we think about minimally invasive dentistry, well, what is that? Because a lot of people think that it's just being as minimal as you can operatively, basically, just not operatively doing things on the teeth. Actually, it's a little bit more complicated than that, and it's a systematic respect for natural tooth tissue, which doesn't mean that you can't remove it, particularly if in removing it, you're making what you're delivering, or you're making the structure that you're removing it from more robust and more resilient. So what does this actually mean in practice? Well, the first point that I would make, and I see all sorts of different cases on my end in the dental hospital, is that it's really case specific. There are situations where we have to remove tooth tissue, but only when it's necessary. And what minimally invasive dentistry essentially means is that whatever we're doing therapeutically, we're not needlessly removing tooth tissue. The question then is what's necessary? And if you look at this case, for example, this is a case of amelogenesis imperfecta, but what would be necessary here when composites which are trying to be bonded to those tooth surfaces are failing? Actually, what might be necessary is apparently a lot more invasive than what might be necessary in other cases that deliver the same caries risk, for example. When you look at these upper occlusal surfaces and you see on the premolars that these composites are already failing, what is considered MID here may be very different to other more straightforward cases. So let's go back to the policy lab for a second, and let's look at the ICCMS, the International Caries Classification and Management System. You may be well aware of this, in which case that's fantastic, but still a lot of people are not really aware of ICCMS and ICDAS and 4D caries care as a concept, which takes us through the process of determining risk, detecting caries, deciding what to do, and actually doing it. So, as I say, this is the International Caries Classification and Management System. And it follows on from ICDAS, which is International Caries Detection and Assessment System. So ICDAS is a way of classifying and assessing caries, and ICCMS is a system for managing it, which is based on risk and based on preventive measures. So when you consider both of these, you have a very comprehensive approach to caries management. Now, if you go online and search ICCMS or ICDAS, you'll find an excellent PDF which takes you through very comprehensively the evidence base around these approaches and lots of algorithms about what to do, including radiographic assessment of teeth. But it's also a very weighty document, which might take you quite a long time. So I've tried to pull out some of the headline items, including this caries care 4D diagram on the right. You can visit the QR code here if you want to, which will take you to that document. We have covered this more extensively in the other webinars. So if you did want to go back to look at those, then you'll find a little bit more detail in those. So let's go back to some of our clinical solutions then. We also talked in the previous webinar about optimal bonding to substrates. This is really incredibly important. And the bonding strategy that you choose will make a big difference in your ability to make sure that you're bonding to all of those natural substrates, enamel, dentine. We talked last time about dentine, which is aged, which is instrumented, which has been carious, has been carious and is now arrested, etc. All those different permutations. But also, we need to be able to cater for over wet or over dry environments. And with enamel, we want that to be completely dry and we bond to it. But we don't want dentine to be dry or desiccated. We also don't want it to be too wet. So what these modern bonding agents will do, and priming agents, they will essentially take that decision out of our hands. They will cater for over wet or over dry environments, which is a remarkable thing to do, but it significantly improves the prognosis. Particularly when you have situations where you might have slightly deeper margins or you might be slightly less able to control the moisture around your preparation. And in turn, the wettability of those, the ability to drive off moisture, the ability to bond to a range of substrates improves the marginal integrity of your restorations, which reduces post-op sensitivity and marginal degradation. And we've talked in the first webinar about the importance of marginal integrity on the overall longevity of restorations. And what this means from a user perspective, from a patient perspective, is that yes, the restorations don't discolor, they stay in place, but also patients won't get as much post-operative sensitivity. So as I say, we've covered a lot of that previously, particularly around some of the science with that, and some videos with demonstrations of how the bonding agent actually works. So please do, if you haven't already, go back and have a little look at those. In terms of preparations, we want our preparations to be of a reasonable quality. And I see a lot of preparations that dentists do, having been in practice for a while. And in my view, some of the standards slip a little bit, and particularly around protecting the adjacent teeth with these. And we try really hard with our undergraduates when we're training them to get them to appreciate the importance for straight line, long axis orientation, leaving that thin slither of tooth tissue just adjacent to the contact point, so that we don't damage the adjacent tooth. And also features such as having cavo surface angles which are between 90 and 110 degrees, relatively flat floor, a little bit of undercut, etc. And some people say, but with composite you don't need those things. But I would come back to that thought in a few moments' time. So when you're looking at your posterior approximal preparation, obviously caries most of the time is starting just below the contact point. So it's really, really important that we do clear the contact point. If you're looking down at your preparation and you still have contact with the adjacent tooth, then you need to take that preparation further, and you need to make sure that you can see clear distance between the two teeth. Again, cavo surface angles of around 90 degrees are really important to give you a robust interface with your restoration. There's no problem with putting composite into place when you have more fragile cavo surface angles. But what it does, it puts much more strain onto that bonding interface rather than allowing mechanical resistance. The more mechanical resistance you have to your restoration, the less strain it will place on the resin bond, and the less degradation you will have at the interface. And in turn, as we've said before, less marginal degradation, less micro leakage, less sensitivity. When you prepare your posterior approximal, you also need to make sure that you're protecting the pulp, and that might seem a very obvious and probably patronizing thing to say, but actually we still, as a profession, particularly in the UK, are very in the habit of sitting in the 12 o'clock position with our patients. If we look around Europe, we find that operators are much more likely to be moving around the patient, even where we might think our nurse or assistant traditionally is. We see that as a no-go zone often, but we should be able to move around the patient so that we can get good view, good instrument control without blinding ourselves to what we're doing. Because often we find with posterior teeth, particularly on the lower arch, that actually operators are not operating down the long axis of the tooth. And often we have preparations which are angled too much towards the body of the tooth, which create large interproximal lipping, which is very hard to manage. Or we have preparations which are approaching the distal tooth too much, and we actually risk damaging the surface of that tooth. And we also don't have a resistant floor to that preparation. I'm sure you, like me, will all have had situations where you've prepared a posterior approximal that doesn't seem to have any form. You keep losing a form to it. It doesn't seem to have a floor to it, and that's really frustrating. And also situations where you just have a really lipped preparation as well. And that's really all about the angulation with which you're preparing. But again, this relatively flat floor is useful because on an occlusal loading, which is significant in terms of an occlusal force, if you have a relatively flat floor, then it provides some axial resistance form. If you have a sloped floor, then again, your restoration is going to be applying a degree of shear force to the base of that preparation. And the first thing that relies on to help keep it in place is your resin bond. So again, we want preparations which reduce the load, if you like, on that resin interface. And for the same reasons, we don't really want any unsupported tooth tissue either. Undercut, again, I'm still a big believer in a small degree of undercut when we prepare our posterior approximals, again, because that physically locks the restoration into place, and it doesn't really take much. It can be, it could even be 50 microns on each side would probably be enough. It can be very subtle to create the undercut, but again, what that's doing is it's reducing the stress on the resin interface. The other thing which will improve the outcomes with our composites is the way in which the material is contoured and the way it handles. This is really important, and this has come on a long way in the last 10, 15 years with materials. And the materials that I'm referring to tonight from Dentsply Sirona are Spectra ST and also SDR Flow, which is a bulk fill flowable. And we'll talk shortly about the different ways in which they can be used. But if you think about how easy it is on a daily basis for you to sculpt material, whether it stays in place in the cavity, whether it sticks to your instruments, whether it's sculptable or whether it slumps, they're all really important things. And also how well it adapts. Now, you won't always see this as an operator looking on your cavity or your restoration, but there's a reasonable amount of work that's been done looking at how well these different materials adapt internally into the deeper features of your preparation. And that's really important. You don't want air blows or air locks in your restorations, and you want the surface to be wettable enough that the material does engage the full surface area, but also you don't want the material to be flowing out of your cavity or your preparation. You don't want it to be slumping as you turn around to either pick up your curing light or to get more material. You don't want that to be slowly changing shape. That would nowadays not be considered a nice feature at all. And of course, not to be too demanding, but we want our composites to look good. These materials now have a lot of chameleon effects. They pick up a lot of color and light transmission from the adjacent natural tooth tissue, which is a really clever thing for them to do. And finally, we don't want to be adjusting our materials when we finish them. We want to be finishing them and leaving them alone, perhaps with a small amount of surface polishing. But we don't really want to be having to change the shape. We don't want to be having to cut things back, because not only does that waste time and leave a flawed finish, but also that particulate is essentially just being sucked up and it's going down the drain. And the other thing that's really important nowadays is that we want to be efficient, we want to be sustainable, we don't want to waste things, and we also don't want to have to dispose of materials which are not used when they should be. We're all aware of the situation, or a lot of you, perhaps my age or older, will be aware of the composite box, where some shades were very popular and used very often, and you'd have other shades which just accumulated in your stock cupboard or in your surgery, and in the end had to be thrown away because we just hardly ever used them. And we've kind of moved away from that approach a lot with Spectra ST and the ways in which it has a chameleon effect. So we'll talk about that a bit later on. So I've put a QR code here, which will take you to the DS website, so you can explore a little bit more about Spectra ST in your own time. But the huge advantage amongst many here is that the materials are available in different viscosities. So we have the high viscosity for posterior packing. We've got a lower viscosity, which is a bit more creamy, a bit more spreadable, a bit more sculptable. But then we've got the flowable for flowing on demand in a various range of applications. And if you look just to the bottom left, you can see the approach that Dentsply Sirona has had for a while now around its universal cloud shades. And this is a really interesting concept, very effective concept, but essentially you only need to have 5 shades rather than the full range of Vita shades in your composites because of the chameleon effect within the material. I'm not sure if the team still have access to this video, but there was a remarkable video which was made by the team in Germany, where they cut anterior approximals out of all of those teeth that you can see on the Vita shade guide there. They actually cut class 3s into them all, and they restored them all with only the cloud shade that sits below them. And when you look to the naked eye, you actually can't see any difference between where the restoration is and where the rest of the demonstration tooth is. And when you pick up a UV light, you can then see all of your approximals sitting there in place, which is a really great way to show how effective that cloud shade technology is. But because of that, we get a simplified shade matching. We get a very, very adaptable and sculptable material. I really like using Spectra ST. And of course, as I said before, you have the choice in viscosity. But there's a good balance here between materials which are durable and aesthetic. And as I say, if we make our decisions in the best way, we finish our preparations properly, we bond properly, and then we use these materials as part of the workflow, then we have durable restorations that last. I will talk a little bit in a moment about bulk fill, because SDR flow is the workhorse really here for how you're filling up the majority of your larger cavities. But then the ability here to just pick up Spectra ST as a capping composite is really important. You only need to be using it for that last millimeter or so to give your final occlusal form. So here we are, SDR. And again, what this is taking us away from is that complex conventional procedure of incremental placement of composites in the oblique fashion to reduce kind of C factor and reduce that stress, that internal stress, flexural stress that happens on the tooth. So with SDR, we're able to bulk fill up to 4 millimeters in one placement. But this is a really clever material because it does a number of things which make it different to just perhaps standard flowables. So if you think about normal composites, the value is probably a little bit lower, but they shrink by, in some cases, up to 3% on polymerization, which means we have to use this incremental approach, layering, particularly in multi-walled cavities. So, as I said, SDR can be placed in 4 mil increments. What's really interesting about it, though, is it's self-leveling. And it adapts the cavity, even areas of undercut. Now, that's really important because, as I said before, you don't always have full visibility of where your material is sitting in the internal anatomy of your cavity. And also, there's no need for a conventional flowable liner. Some people like to place a flowable liner to make sure that you've got adequate adaptation on the base and a relatively flat base at which to continue placing composites. But there's no need for that with SDR. It can be incorporated into that layer. And it's incredibly quick because you dispense it into place from the compule and then it's cured. So it's up to 40% quicker than layering. And more recently, as part of the workflow with SDR, we have a number of different shades that you can use rather than being a single shade. So if we have a little look at this video here, you can see that self-leveling, adaptation, and it's not slumping. So really important. Here we go. So again, I would emphasize the fact that it doesn't slump and it doesn't flow, but it self-levels to the walls of your cavity, which is a really, really useful thing. If we look at how it copes around the margins, again, really, really important. But if we think about packing conventional composites, as you can see on the bottom left, inevitably we end up with some voids, some discrepancies. And you can see that when we apply the material to a kind of a synthetic cylinder, which you can see on the top. And the only way to get that material to conform to the anatomy is to try and pack it or to agitate it or to warm it. And some people do all of those things. Either way, it's a reasonable amount of effort to get that composite to adapt. With SDR, you simply dispense it into the cavity and it will take up even the finest detail of cavity form. And this is, for me, one of the most significant benefits of SDR is its ability to adapt, because it's the voids that you don't really see, particularly if you go slightly subgingival to the base of your box. You won't see those discrepancies. You want to know and be confident that as long as your matrix is adapted well, that by applying this material, it will adapt to the cavity form. So as I say, some people pack, some people agitate, some people warm composites, but all of those things take a degree of time and effort. And as we saw in the video, SDR flows itself into cavity spaces and adapts itself without slumping. And as I say, for me, it's about having predictable marginal integrity rather than wondering, have I done enough on this occasion to make sure that I don't have any voids or any discrepancies. If you look at the difference here in the detail that this picks up with a packable composite that's been packed against a matrix into the base of a box, you can see what that looks like under magnification. But if we do the same here with the SDR, you can just see how completely different the same cavity form we have there, with its ability to really flow down into the very fine aspects of the matrix where it adapts against the wedge to the tooth. Really quite a profound adaptation there. So let's go back to our research lab for a second and have a little look at how these things behave when they're being tested. So there's a paper here, which is a 5-year randomized controlled clinical study looking at different posterior bulk fill resin composites. And what this is showing is that SDR demonstrated the lowest shrinkage stress of all of the bulk fill materials that were tested, which is a very good result. And SDR bulk fill at 5 years showed a slightly better durability compared to conventional 2 mil layering technique in normal resin composite restorations, and there was no post-operative sensitivity. Now, important to note that in the data that a slightly better durability was not statistically significant. However, even if it's not and it's the same, it's a lot quicker to place. So either way, it's supporting the use of this SDR, this bulk fill composite. I spent quite a lot of time last time talking about adequate adaptation of matrices, because again, it's really important when you think about what that material is doing right down in the depths of where your matrix meets your tooth. If that isn't a robust interface, then it will degrade, it will leak, and you'll get problems with the with micro leakage, with the seal of your restoration, but also potential problems with sensitivity too. So the matrix system that you use will make a big difference in terms of how you manage excess material, whether you achieve a contact point or not, this anatomical and in the right place, how well you adapt the base of the box, and how well contoured your final restoration is, and in turn, how much finishing and polishing you have to do for your restoration. And we talked last time about the Paladin system and the value that has in terms of managing the restoration. So if we think about circumferential bands, for many years and still in many places, these are the workhorse of large restorations. But the problem with this is that they require separation at 2 points on a bounded tooth. And you'll all be aware of the situations where we wrestle to get these matrices into place, and sometimes we wrestle to get them off again, which can be frustrating. They also require a wedge, which, if it's a conventional wedge, can somewhat traumatize the soft tissues, because the band itself often is not anatomically contoured to follow the kind of the sweeping nature of the tooth below the contact point. So we end up having to actively push the band against the tooth and hold it there with quite a thick wedge. And it can be difficult to obtain more coronally anyway, an anatomical contour. You can see here how already this is emerging from the tooth very much like a cone. It's not converging back again in that rounded fashion like we might expect to happen with a marginal ridge. And it can end up with us, we can teleport or move marginal ridges away from the proximal surface they should be in, and they can encroach too much on the adjacent tooth. And we can have very broad, sharp contact areas rather than contact areas which are lower and more rounded. And as you said before, sometimes if you try to remove the band, frustratingly, you can fracture, and even in some cases you can debond your restoration. So if we look again at sectional matrices, the Paladent V3 system with Dentsply Sirona is a very intuitive system. There are other sectional matrix systems on the market, because I think people have realized now that this is a very efficient and pragmatic way, especially with composites, especially when we don't need to be packing with the force that we used to pack amalgams with. We can't afford to do that anymore, and we have to be more gentle with composite. But what that means is we can more reliably and predictably employ a sectional matrix system, which, as you can see from these bands, has a much more anatomical shape and is much more efficient. So that Teflon coated matrix means that the composite doesn't stick to it. You've got a greater curvature to those sectional matrices, which means that simply by placing the composite against them, you're already getting that natural curvature in the restoration. The tines themselves separate the teeth slightly. So as you relieve them again and remove them, and the teeth relax back, you get nice tight contacts, and we get minimal flash because of the adaptation of the wedges against the matrix. And also these wedges are designed to be used specifically with this system. And as you can see in the top photo, they can be used between the tines as well, so they don't interfere. Now, I did say this last time, but I use the Paladent V3 system. We certainly teach it in our dental school. Many do, but I do prefer sometimes to use wooden wedges with the system. I think that sometimes we assume by putting a wedge in that it's doing its job, and when you actually go and check with a probe on the internal fitting surface of the cavity, you notice that actually it's quite easy to push the band away. So that we need strategies to improve the adaptation of the matrix to the tooth. If you ever go and test that and you realize that it's not a firm adaptation, then you might want to elevate what you do from a plastic wedge to maybe a wooden wedge, or even, as we'll mention later on, using a little bit of PTFE tape to pack in interproximally to hold that band against the tooth. There's also something called the wedge guard, which I think I've got a photo of in a second, which is a mechanism that allows you to afford a little bit of protection for the adjacent tooth as you're preparing your approximal cavity, which is then removed to leave your wedge in place. And of course, we have a choice of different tines for different parts of the mouth. So if we have a little look here at sectional matrices, you can see on the top row what happens when we remove, this is very typical to see this, the matrix after placing a composite restoration. And the first thing that we're doing as soon as we take it off, of course, is to pick up either a high speed or a Softflex disc, for example, and start to try and recontour that excess around there. But inevitably, even if we do that, we don't reduce the contour enough, and we end up with actually a lot of composite sitting over tooth tissue that we didn't even etch and bond, which is an invitation for microleakage in the first instance. But it's a lot of work to bring that back round to the normal contour. If you can see, as we go down to the next set of images in the middle, you can see that by having a sectional matrix in place with a wedge, that without any finishing at all, as soon as we just take that off, yes, there's a bit of finishing to do, there's a little bit of flash to manage, but it's a lot less than if we use the circumferential matrix, and it's going to take a lot less time with a lot less waste to modify and to improve the outcome. And again, you can see on the very bottom images the difference, conceptually the difference between a linear walled circumferential matrix, which gives you that very high tight contact, which shreds floss and food packs underneath, compared to your more anatomically positioned contact point, which is more sympathetic to passing floss through and less likely to trap food interproximally. And Dentsply Sirona, a number of years ago now, did some work to show that the finishing and polishing of composites that were used with circumferential matrices represents up to a fifth of your clinical time, which is huge. When you think how long you sit in front of your patients each day doing restorative work, a fifth of that time is huge. So using something which is anatomical will save you a lot of time. The other thing around sectional matrices is that they're easier to assemble and they're a lot easier to dispose of with a lot less waste. And still one of the biggest reasons for sharps injuries in dental practice is dismantling of matrix bands, particularly circumferential matrix bands like scaland. So yeah, it's a good reason to reduce waste and also to improve safety. So I mentioned before the wedge guard. You can see how that works here with the different sized wedges. And once you finish doing your preparation, then you can remove the metal aspect, which leaves the wedge in place. Now, I do not give these to our students. We train everybody as highly skilled dental surgeons. You shouldn't need one of these to not damage the adjacent tooth. It's very nice of Dentsply to produce them, and they probably are useful as a peace of mind. We don't use them with our undergraduates because it gives them a false sense of security. But as qualified practitioners, it might be something which you feel you want to use, and just gives you that extra layer of predictability. It also gives you a bit of reassurance if you're working next to a highly polished surface where you really can't afford to roughen, or you really wouldn't want to roughen the surface because it's going to be very difficult to polish that up again. And as I say, the removable guard means that wedge still stays in place after. And this is what it would look like before you do your preparation, before you lift that out of place. So what might the other benefits of the Paladent system be? Well, again, the tines come in two sizes, molar and premolar, which are designed to sit over those wedges. You've got 4 sizes of anatomical band, and the wedges are actually stackable, so you can put more in if you find that you want greater adaptation. Now, as I say, often I pick up a wooden wedge at that point, but if you were a purist with the system, you would continue to stack those wedges. And you can see some pin tweezers there, which have a reverse action to stop you from accidentally dropping those very thin little sectional matrices. But it makes it very easy to pick them up from the little pinhole that you can see and to position them into place, and also to pick that up again afterwards. And yeah, some of the little things to do with features that help visibility when you're looking into the materials box. So let's go back to sustainability for a second, because again, I want to visit this notion of polishing. There's some good research out there that shows that there is a degree of particulate produced when we are polishing composites. You'll all be aware of this if you ever do any kind of polishing without the water on, with discs or strips, but it generates a huge amount of dust, particulate dust. Now, the danger of adjusting composites under water flow is that you don't see any of that. It just gets sucked up down your high volume aspirator and it goes down the drain. Now, we've had, in the UK, we've had amalgam separators for a long, long time, but we don't have anything which separates out microparticulate, which is composite base, and that all ends up in the environment. And as we've seen before, there are some pretty or not particularly nice products and chemicals in those substrates which are sucked up and sucked away. So if we know that polishing composite restorations occupies around a fifth of clinical procedure time, that's a huge amount of particulate waste that's not filtered. And what this study here was showing was that all types of composite release significant amounts of nano-sized particles, and that in turn they have negative effects on bronchial epithelial cell viability in humans, but who knows really what environmental effects they will have as they move through the environment. So the message here from a sustainability point of view is reduce the biological effects both on patients but also on the environment in having to polish things in the mouth. I'd also just like to mention about predictable restorability, because before you plan an intervention for a tooth, you should be able to make a decision about how restorable it is. And you'll all be aware of the situations where we're battling to restore teeth. We may have even restored them and it's failed, and we're troubleshooting that again. But then part of you thinks, I'm not really sure that restoring this was such a good idea. And, you know, as dentists, we can restore things. That's what we're trained to do. That's not really the problem. It's whether it's predictably restorable. And the same goes for indirect restorations. You know, a lab technician will invariably be able to make something for you for a tooth, but how predictable is it in its longevity? And therefore, is it the right thing to do? And certainly, does the patient have consent to do that? How long will it survive? What might the complications be if it starts to fail? Do you feel happy in yourself that it's the right thing to do? And do we therefore have patient consent? Have we talked to the patient about the fact that something is suboptimal? Something may have a guarded prognosis. And what might the consequences be of going ahead with a restoration? And in that sense, do we have patient consent? You can see here the Dental Practicality Index is one of the numerous ways in which we can assess restorability of teeth. Andrew Darwood here has published this paper where it issues different levels of structural integrity to the tooth amongst other parameters. And it allows you to determine what would be considered predictably restorable or not. But actually, if we take this concept a little bit further, it takes us on to the concept of deep margins. And this is something which some of you will want to bury your head in the sand with. Some of you will be the opposite and will relish the challenge of a deep margin. Some of you will be very confident managing deep margins, and some of you less so. I take the view that anything that's happening below the gingival margin means that there's a degree of unpredictability with what we do with patients. Trying to teach our students that is a challenge, but trying to maintain confidence in them with what they're doing at the same time is equally as challenging. Anyone can learn to use a matrix. Anyone can essentially place a restoration which is elevating a deep margin. But the questions you have to ask yourself are, should you elevate it? And if you do, what will the effects of that be? Do you have a suitable way? And I mean, do you personally have a suitable way of predictably carrying it out effectively? And in the same way that I mentioned it before, do we have patient consent? What might happen if we are working subgingivally with a deep margin and we try and restore it? That brings us on to the concept of supracrestal attachment, which for those of you, again, that are my age or more, we'll talk about biological width or biologic width. But the new terminology is supracrestal attachment. And this is the band of tissue that's coronal to the alveolar bone crest. So back in the day, a lot of the seminal studies were done on cadavers, and they demonstrated that essentially this supracrestal attachment, this biologic width, is around 2 millimeters. But the epithelial attachment component of that is actually very variable. And that's one of the messages which I try to get across to our students a lot of the time, postgrad and our specialty trainees, is that you don't really know in any given patient really what their supracrestal attachment dimensions are. So the connective tissue component of that might be relatively consistent, but you don't really know how variable the epithelial component is. So what happens if we encroach on that supracrustal attachment? Well, one of three things will happen. If we go beyond that intended sulcal depth and we start to encroach on that supracrustal attachment, then we either get chronic periodontal inflammation, because what the body's trying to do here is to remodel that periodontal apparatus away from whatever is annoying it, which in our context here is essentially a foreign body, particularly if we've got open margins or poorly adapted margins or lipping or ledging, because it will be a haven for biofilm bacteria. As a result, we may get clinical attachment loss, we get recession, and bone loss, or bone loss and then recession. So it's really important that patients understand that if we're going to have a go, and there's nothing wrong with actually wanting to place a deep margin or even to elevate a margin so we have a more controllable superficial margin to work with, patients need to understand that these things have the potential to happen. Most of the time, patients will say, well, that's fine. I'd like you to carry on anyway, because I think on balance, the risk, I'd rather have a restoration attempted than the other options. But at least you've got patient consent at that point. If you don't talk to patients about that and these things happen, then you find yourself in tricky water, because really we should be consenting to those things. So the nearer your margin, your subgingival margin is to that epithelial attachment, the more likely you are to have severe inflammation. So what should you do? Well, ideally leave a minimum of 3 millimeters from the restorative margin to the bone crest. That's probably relevant if you're able to control and have the flexibility to control where you finish your margin, particularly if you're preparing for extracoronal restorations. If the supracrustal attachment is involved, or you think it will be involved, then you need to move the restorative margin away from the crestal bone. And how do we do that? Well, we either do it formally through surgical crown lengthening, which is where we actually raise a flap, we remove alveolar bone, and we replace the flap, and through resolution, we essentially get apical migration of that periodontal apparatus. Or we extrude the tooth orthodontically, or we actually proceed with patient consent to place a restoration which we believe has an optimally adapted restorative margin, on the understanding that we will monitor it and review it on a continual basis. And that's my position on this, particularly in terms of how we teach our students. But I'm not sure this is the position of many people out there who are just restoring margins which are subgingival. So with that in mind, though, it's very difficult to control moisture effectively at the subgingival margins. And so there is the option, of course, of not necessarily using a resin-based system for the deeper part of these restorations. You could consider using a glass ionomer, where those ionic bonds are less affected. Amalgam was incredibly useful here in this context, but we don't have that anymore. But what that glass ionomer restoration will do is to raise the margin enough that it's in a more predictable position for you to then create a restoration with resin composite. So it's an option if you didn't necessarily want to be using composite below the gingival margin. And of course, going back to what we said in the other webinars and earlier on, is that using primer bond active will help drive away excess moisture that might be happening because of that gingival crevicular fluid subgingivally, and give you a more optimal outcome, a more predictable outcome. So back to our research lab here, back to Oliver Bailey's work from the year before this time, a very good paper on sectional matrix solutions. And what he's doing in this paper is he's talking you through the sectional matrix technique and ways in which you can improve adaptability, improve that cervical seal, and actually reduce distortion of the matrices themselves. Sometimes the way in which we use the clamps can introduce distortions into the matrix, which aren't helpful. But I've just put up a couple of examples here of useful summaries, which he creates in the paper around how you can, things that you can do to improve adaptation, improve cervical seal, coronal stability, etc. And there are some good pictures in here, high quality pictures, which allow you to understand what he's proposing, including the use of some separators, Elliott separators, etc., which you probably don't come across very often in your clinical practice, which can really help and are slightly different from some of the more mainstream systems out there. To go back again to marginal adaptation, it all brings us back to this, that we want predictability around the margin. We want integrity at the margin. And again, primary bond active is going to help you achieve an optimal bond with reduced microleakage and therefore reduced post-op sensitivity. And the matrix system is going to give you anatomical contours and marginal adaptation. And SDR is going to allow you to achieve the correct restoration profile, and it's going to allow you to reduce flash and marginal defects and save you time, because you simply have to then place your capping composite layer as the last layer. In terms of finishing, this is really something which is close to my heart, because a lot of people do significantly change the shape of their composites when they finish. And as we've said already, you would ideally finish the composite before your final cure in a way which needs very little adjustment after. But whatever you do bear in mind that finishing and polishing and adjusting are quite different things. Polishing really is changing the surface finish. But if you want to change the shape, then you're having to recontour. And very rarely can you do those things with the same system. Often many operative dentists will blur the lines between polishing and shaping. To change the shape, you're going to need rotary burrs, coarse discs, cones or stones that essentially grind the surface. If you try and change the shape with a polishing system, you will inevitably just waste the instruments that are meant to be for polishing, or you will overheat the tooth, or both. To polish things, you need 3-body wear to change the surface finish, but you don't want to change the surface shape. And so you can understand here how there's a need to have different systems for physically changing the shape of something and for finishing it. Now, traditionally, that would have meant working through a range of discs or strips. So with the more coarse discs, you're changing the shape. And as you start to put on the finer discs, you stop changing the shape and you start to polish and finish the surface. And that's why traditionally people have said you have to work through the full workflow of discs. But of course, we get impatient and we skip them. We don't do that. And we end up essentially going to the finer discs and strips when we haven't really prepared the surface enough for polishing. And we end up overheating the tooth. We use the system, but it's not really giving us the finish that we need. The enhanced system from Dentsply Sirona, if we take ourselves to the latter quarter of that process, allows you to actually finish and slightly change the shape to a degree in one step. So as we apply more pressure to this system, it will actually begin to physically remove composite from the surface. And as we apply less pressure, it will act more with 3-body wear to polish the surface. And this is quite an interesting system. It makes it a very efficient system towards the latter part of your polishing. I would still say that if you need to significantly change the shape of what you've done, you need to pick up a coarse disc or a rotary burr. But then going straight to the enhanced system allows you, certainly in the latter parts of those stages, to be quite efficient in what you do. So in summary then, and we're summarizing quite a lot here, to be fair, but we should only remove tooth tissue when we feel it's absolutely necessary. And I do honestly believe that we should still prepare posterior approximals if we're going to remove tooth tissue at all, we should build in resistance and retention form to what we do. We have to ensure that marginal integrity is maintained for all the reasons we've said before, including reducing degradation, microleakage, staining, and postoperative sensitivity, recurrent caries. But we should also plan the use of matrices carefully as well, in understanding what they're able to give us, not just in terms of efficiency, but in terms of improved anatomy and reduced polishing time and waste as well. And finally, just to be mindful of deep margins, making sure that we have got patient consent for what we're doing, even if you're very skilled and able to be predictable in what you do. Patients are patients, they're biological human beings, and not everybody will behave in the same way. As soon as you go subgingivally, you can guarantee that there is something unpredictable in that equation. So making sure that patients just understand that there are some risks with what you're doing, and having that documented is a really important thing. So just to check our learning outcomes, we said that we'd discuss some fundamental concepts of cavity design. We said that we'd discuss the options and indications for using composites and on occasions some other restorative materials. And we'd explore the challenges of and the solutions for managing subgingival margins. So I hope that's been useful. I'm going to stop sharing my screen so that we can have more of a conversation around things. Hopefully that was okay. And actually most people are still there, which is fantastic. Having a little look. I haven't been able to see anything during that, by the way, Christian, because my laptop screen has been filled up with the presentation. So
that's absolutely brilliant. A massive thank you as always, James. That was a brilliant presentation again. I'm just going to